Pratham Majumdar. He is a good friend and senior consultant in the Department of UVA and Intraocular Inflammation at Shankar Nethralaya, Chennai. He has published many articles in various peer and non-peer-reviewed journals, has served as editor and as section editor in the past. He has written 65 chapters in various ophthalmology books and edited 4 books. He has authorized 2 scientific monographs on polymerase chain reaction in ophthalmology and scleral inflammations published by AIOS. He is now serving Indian Journal of Ophthalmology as assistant editor UVA section and as a member scientific committee of Uveitis Society of India. He is the founder cum chief editor of the popular ophthalmology portal eophtha.com. May I now request Dr. Partho to please present his views on managing scleritis, which is again a very challenging scenario for us.
Thanks, Dr. Chekitan, for inviting me to this wonderful instruction course. Good evening, friends. So I'll be talking on decoding the enigma of scleritis. So as usual, I always put this slide. Those who will be watching this video live in YouTube or some other media, if you have any query, you can just write to me. I'll be happy to answer your query. So coming to the scleral inflammation, the most important question we have is whether the inflammation is scleritis or it is episcleritis. So I won't go into the examination because already you know that episcleritis means the superficial vessels are involved, and in scleritis, the deeper episcleral vessels are involved. So you have to basically look for the 3 important findings. One is the pain. The scleritis patients will complain of severe boring pain, and often the pain will increase at night. The second point is you will have a lot of difficulty to examine that. There will be a lot of tenderness. The third, the most important step in your clinic can be done using a topical vasoconstrictor like phenylephrine, which will blanch the vessel in episcleritis, whereas in scleritis, the vessels won't be blanched. Now, coming to the subtypes, you have to identify the subtype of the scleritis. So when we talk about the subtypes, ora serrata is the landmark here. So when the inflammation crosses the ora serrata and goes to the posterior side, we call it posterior scleritis. Otherwise, it is known as anterior scleritis. So anterior scleritis diagnosis is almost always clinical. You don't require any ancillary test normally. And though there are a variety of presentation which will be dealing now. The posterior scleritis, on the other hand, it has less obvious clinical signs and often requires imaging to reach the diagnosis. Anterior scleritis, based on the presence of necrotic area, can be divided into broadly 2 types. One is non-necrotizing, another is necrotizing. The non-necrotizing can be diffuse and can be nodular. The diffuse can be diffuse is the most common variety of scleritis and often associated with anterior uveitis. The nodular variety, often it presents with a painless nodule. Sometimes it can be very painful. So in our study in Shankar Nethralaya of more than 100 patients of nodular scleritis, we found that TB is the most common cause in these patients, and followed by the rheumatoid arthritis. So next time when you look at scleral nodule which is not responding to your immune modulatory treatment, think about tuberculosis. And even if it is non-infectious cause, the nodular scleritis is known to respond very slowly to the treatment. So you have to give them relatively longer anti-inflammatory treatment. Coming to the necrotizing variety, there are 2 types, with inflammation and without inflammation. Sometimes it's very difficult to distinguish between them. The with inflammation actually basically characterized by the avascular area of localized scleral edema, and you can see the edges of the inflammations are more inflamed than the center. Now, without inflammation, it has minimal or nil congestion. Sometimes they can present with the absence of pain, and these are basically seen in long-standing rheumatoid arthritis. But as now we have a lot of disease-modifying drugs for treating the rheumatoid arthritis, we are very rarely encounter this kind of conditions. Coming to the posterior scleritis, it is one of the most underdiagnosed but treatable conditions in ophthalmology. It's very difficult to diagnose it because it has a protein presenting manifestation, and sometimes we see the patients with posterior scleritis, but we don't consider the clinical entity. So the diagnosis is often missed because we don't consider the posterior scleritis. So it can present as a mass, which sometimes we can think as a oncological entity or as a tumor. The second one, it can actually present as a lot of choroidal folds. Sometimes we think it as a Vogt-Koyanagi-Harada disease, and sometimes it can present with significant bullous detachment or exudative RD, and sometimes there can be a nerve involvement. So there are variety of symptoms, variety of presenting signs of the posterior scleritis. Now, imaging is a very important. Ultrasound B scan remains the most helpful tool in these conditions. But as you can see here, this is a photograph of a posterior scleritis patient with a T sign. But you must remember that T sign is not mandatory for the diagnosis of posterior scleritis. It can occur even with the T sign. So FFA has a limited role because it can, if there is significant subretinal fluid in the fundus, in retina, then you can find the early pinhead leak and placard pulling of the dye, which can be seen in various other conditions like in VKH, like sympathetic ophthalmia. Now, one thing you have to understand is the systemic association. Normally, the 50% of the patients can have underlying systemic disorder. The rheumatoid arthritis is the most common systemic rheumatic disease, and the granulomatosis with polyangiitis, previously known as Wegener granulomatosis, is the most common systemic vasculitis associated with scleritis. There can be relapsing polychondritis, systemic lupus erythematosus, polyarthritis nodosa. These are the systemic entity can be associated with scleritis. But when we are talking about necrotizing scleritis with or without corneal involvement, this risk can go up to as high as 95% also. So remember that necrotizing scleritis and corneal involvements are the red flag signs. This can be manifestation of a lethal disease. So you need to start aggressive management, and you have to send the patient to rheumatologist's opinion. Treating early can save the life of these patients. So you have to take a proper history, like you have to take history of surgery or trauma to rule out the infectious scleritis. You have to take the joint pain, joint stiffness, note their symmetry, what kind of duration they are presenting with, whether they are related to any activity. You have to take the history of the drug, because some patients will be taking biphosphonate, which is notorious agent to cause scleral inflammation. So these are the very in history you have to take, and you have to look for the systemic sign like butterfly rashes. You have to look for the deformities like in rheumatoid arthritis. Look for the necrotic digits in systemic vasculitis, and the depressed nasal bridge, which can be seen in Wegener granulomatosis because of the destruction of the cartilage. Now, the laboratory investigation, normally we perform the rheumatoid arthritis antinuclear antibody, and in necrotizing scleritis, we go for the ANCAS. But you have to remember that no single test is diagnostic or specific. There is no standard of battery of investigation. You have to take the help of history, clinical signs, and systemic sign, and then only you can go for the laboratory signs. I'm sorry for the typo. So you have, for example, if you have a patient with photosensitivity, diffuse scleritis, and butterfly rashes, then you can advise the patients with antinuclear antibody as dsDNA. So suspect infectious scleritis, if you are seeing this kind of patient like scleritis associated with visible pass point, scleritis associated with hypopion, scleritis with conjunctival necrosis or ulcer, and scleritis not responding to therapy. Any scleritis not responding to conventional therapy, you should think about. The management is normally we treat them with topical steroid, oral NSAID, and then go to systemic steroid. And if they are not responding, then we go to immunosuppressive and biologic. But if it is a case of necrotizing scleritis, the first line treatment should be the immunosuppressive and biologic. So not in necrotizing scleritis, always send the patient to a rheumatologist, but tell him that how serious is the ocular involvement and what kind of therapy you want. If you need a urgent aggressive therapy, you have to tell this to clearly to your rheumatologist so that he can start the therapy in your patient. Just to conclude, you have to remember that the systemic rheumatic disease is very important in scleritis, so you have to rule it out. Corneal involvement and necrosis are the red flag signs. Laboratory tests should be ordered based on the clinical findings and history. Enquiry for the systemic sign and looking for them are very helpful. Rapid and effective treatment can save not only the eye, but also life of the patients. Aggressive therapy is must for patients with necrotizing scleritis. Thank you for patient hearing.